So we have only one case today, and we will make a little bit discussion on initial approach for this particular PV patient, and then we will delve into refractoriness and new coming possible treatment options, and we will hear Dr. Tefferi's insights. So I will go over this case. This is a 65-year-old female patient with a history of CVA, presented to emergency room with headache, pruritus, weight loss, and her blood pressure found to be 180 over 120 with hemoglobin 18.8. And then the hematocrit was 53% with WBC 10. Platelet count was 240. LDH was 800. Her coag lab was unremarkable. EPO was normal. And her spleen was extended 5 centimeters below the left costal margin. And then when she was further tested, she was found to have a JAK2 mutation V617, VAF of 70%. And later bone marrow was done with the hypercellularity for age 60% with a grade 1 reticulin fibrosis. There was no cytogenetic or NGS abnormalities. So again, the first question comes to most of the people's thought: when can we omit the bone marrow biopsy when we are making the formal PV diagnosis?
That's a very good question. And as I always tell my students, and actually my peers as well, when you are planning to do an invasive procedure that is expensive, you have to ask 3 critical questions. One is the information I am going to get help me manage this patient better? Is it going to affect my treatment? That's number 1. Number 2 is, regardless of treatment, would it help me prognosticate this patient better? And the third one is, does the patient care? The patient has to be in agreement with your intentions and your logic of doing that invasive procedure. So if we take that, for example, before I tell you about the PV, I will tell you that I never do bone marrow examination in patients with CML. Never. Unless the peripheral blood smear and the clinical presentation suggest to me that the patient might be in an accelerated or blast phase. There is nothing that I cannot do in the peripheral blood that I'm only able to do in the bone marrow. I can do the cytogenetics also in the peripheral blood. So let's use the same reasoning here in PV. And in most of the times, the information you want to treat the patient and prognosticate the patient, you can obtain from the peripheral blood. You can do peripheral blood next generation sequencing. You can do peripheral blood chromosome studies. And if you know how to read the peripheral blood smear, you will understand how much fibrosis there might be in the bone marrow. So therefore, if you ideally, you can get away without it. You don't get any additional information. However, you need to remember, especially in an academic institution, we got here because we reviewed all the bone marrows in the past in patients, and we learned so much from them. And if we skip the bone marrow now, we can be cute and provide that reasoning I tell you, but we are truncating the science. All this information that would have been available that in the future might become much more apparent is missed opportunity. Therefore, you know that you're not going to do bad to the patient by not doing it. But you might do something good for the science. So you take that together and then you decide case by case. in general, in older patients, I usually don't do it. In younger patients, I do it.
Because the definition is based on the WHO criteria, if the hemoglobin is more than 18.5, that makes counter argument to do the bone marrow biopsy. Is that another reason that we can omit, or is that something that makes more likely the PV diagnosis?
So if you remember, that definition was in the 2016 WHO that we formulated, and we generally consider that if the hemoglobin is high enough, let's say a man over 18, a woman over 17, then you really don't have to do a bone marrow examination. That was the thinking. But in the revision, in the international consensus classification, and also the 2016 WHO, in the revision, we said that the hematocrit level and the hemoglobin level can be lower in order to make a diagnosis if you have the JAK2 mutation. So in that context, the threshold is no longer 18. The threshold is greater than 16.5 for man, greater than 16 for a woman. That's the threshold. This way, we don't miss the so-called masked polycythemia vera, which is that patients in borderline high hemoglobin levels, but otherwise have the JAK2 mutation. So now in this molecular era, if you have a JAK2 mutation and the hemoglobin is greater than 16.5 in a man, you can make the diagnosis. In other words, you will not be missing. The only time you would be missing it is if you considered 18 as a cut point, and then you would be missing everybody between 16.5 and 18, which would be masked polycythemia vera. So that no longer is a case. Now you have to remember something else also, Taha. Medicine is an art. It is not a cookbook. You don't, when you see patients, you make sound judgments based on a number of things, and you don't necessarily have to stick to a classification scheme or what have you. That is a general guideline. For example, if you have a patient that you know have always run a hemoglobin of, let's say, a man, always 12 to 12, 13, okay? And then 5 years, you're following the patient for high blood pressure, and the hemoglobin becomes 15 to 16, all right? And then the patient has a JAK2 mutation. That's polycythemia vera, period. Biologically, that person has increased the baseline hemoglobin level persistently and has a JAK2 mutation. Just because he has not reached this at 16.5, you're not going to say, well, this is not polycythemia vera. So you have to remember that you have to take a lot of consideration. It has to be individualized, and you can't just run into that classification scheme or guideline, or you have to use your own mind. Must practice medicine as an art.
Okay, great. So, so what typical clinically and laboratory findings of PV at presentation and in the long term that do we expect to see with the PV patients?
Typically, more and more people are getting checked for well-being. People are not waiting until they get sick to go to the hospital to get a CBC. They have to check their blood pressure. They have to check their blood glucose, as you know. Therefore, most people are incidentally discovered with high hemoglobin. So I would say a significant amount are asymptomatic. It becomes an incidental discovery. This is more for ET than it's for PV, but that's the case in general. But when the symptoms occur in patients with PV, usually their neighbors, their family members, their friends, they tell them that they look red, facial palmar erythema, fullness in the head, And you may or you may not realize this, but about 60% of patients with PV present with high blood pressure. They have. If you take the blood pressure of patients at diagnosis in PV, the majority will have a high blood pressure. That corrects as soon as you start with phlebotomy. So most of the time they're asymptomatic. But when they have symptoms, it could be headaches, head fullness, and then the typical traditional symptoms for PV, which include aquagenic pruritus, and that can occur in up to a third of patients at presentation. Palpable splenomegaly, again, that can happen about a third of patients at presentation. Interestingly, acral dysesthesias and painful hands and feet, sometimes to the degree of erythromelalgia, that can happen, believe it or not, in up to 10% of patients at presentation. These are the clinical manifestations. If you look at the laboratory, other than obviously the increase in hemoglobin, you'll see about 20% of patients will have leukocytosis, significant leukocytosis, over 15,000. The majority will have generous platelet counts. In fact, about 30 to 40% will have platelet counts greater than 450. That would be the threshold for ET. So it's very easy to confuse the two. And in fact, up to 5% of patients may have platelet counts over 1 million. So laboratory-wise, these are the things that you look into. Now, the old textbook tell you that the uric acid level might be increased, the LDH might be increased, but these are very non-specific. Actual gout is infrequent. But these are, in general, the presentations. Now, if you want to know a little bit more about the genetic presentation, I would say about 15% of the patients at diagnosis will have an abnormal karyotype. 15%. But remember, that number shrinks to about 11% or 10% if you take away those with loss of chromosome Y. As you know, loss of chromosome Y occurs with age. So if you take that out, it's only about 10 to 12% of patients will present with an abnormal karyotype. Now, during the disease process, obviously, there is progressive splenomegaly. Patients can start developing symptoms that are constitutional, weight loss, night sweats, and what have you. And then there is this thing called microcirculatory disturbances or microvascular disturbances, which is a profile of all not wellness, basically headaches, acral dysesthesias, and what have you, which occurs in about a third of patients. But most importantly, in terms of PV, we're worried about three things. One is thrombosis, one is leukemic transformation, and one is fibrotic transformation. Now, in terms of thrombosis, about a third of patients present with a history of thrombosis, usually arterial, but also venous. And then another third will develop over time. It depends. That percentage depends on how long you follow the patients. Again, arterial slightly ages venous in terms of incident thrombosis. Fortunately, the fibrotic and leukemic progressions are lower in frequency. I would say over 10 years, less than 5% leukemic transformation. Over 20 years, less than 10% leukemic transformation. The fibrotic progression is a little higher. I would say about 5% in the first 10 years, and perhaps 15% in the first 20 years, and maybe higher if you follow them longer. So those are, in general, the presenting characteristics and what might happen during the clinical course.
Okay, yeah, thank you. So, so what will be your approach for this JAK2 V617 or the exon 12 PV patients with no signs of fibrosis?
Well, so I suspect that you're asking me how I manage these patients.
That's right. Yeah. How do you certify them?
Yes. So remember, the cornerstone of treatment in PV is phlebotomy. So you start phlebotomy immediately, and whether it is a man or a woman, you want to secure a hematocrit level of no more than 45. So the preferred hematocrit target is below 45% for both men and women. Now you have to remember something. This is artificial. This is man-made. So if someone had a baseline hematocrit of 40 and they have PV and they go to 50, that person probably needs to come down to 40. So in other words, you have to choose these targets based on what the individual's baseline used to be. And if you don't know that, what's the best threshold that the individual feels best in terms of symptoms? So in other words, even though we say 45, it's very flexible. Some of my patients like 38. Other patients say, well, I feel best when I'm 44. So you have to kind of play it around, and you don't just say 45, everybody. No, you have to individualize it. And for some people, it might be lower than the other. So that's the number one thing you should do. That's number two thing is almost universal for all patients, aspirin therapy, unless it's contraindicated. One baby aspirin, 81 milligram, every day for everybody. Now, there is emerging information that once daily aspirin might not be enough to have persistent inhibition of thromboxane formation. So therefore, twice a day aspirin appears to be superior in terms of securing persistent inhibition of thromboxane over 24 hours. So I actually use twice a day aspirin for all my patients in PV unless it is contraindicated. So those are the two. If I do those two, I feel very good. Now, whether or not I need some additional cytoreductive therapy depends on a number of factors. In general, I try to avoid it unless I have to, because those cytoreductive drugs are not going to cure the patient, or they're not going to prolong survival. They're just there with the objective to prevent risk of thrombosis, to prevent thrombotic complications. So if you think about that, the one baby aspirin twice a day is already doing quite a bit for you. If you think about that, the best treatment probably would be systemic anticoagulation, especially now that we have Eliquis and all the other drugs that we can easily give by mouth without too much. Those might be better than any cytoreductive therapy in that regard. But we are not there yet. The studies have not been done yet. So the studies that have been done is using cytoreductive drugs. So the question is, when do I use cytoreductive drugs? In general, in older patients, age above 65, for example, then I add hydroxyurea in order to maximize the protection against thrombosis. Now, in younger patients, there is an alternative now, which is interferon-based therapy. There is no controlled study that shows that interferon is better. There has been several, I would say, at least 3 randomized studies in PV, and 2 of them in high-risk patients, and 1 of them in low-risk patients. Again, all those studies in general have not shown superiority of interferon over hydroxyurea in terms of meaningful health outcome. Talking about survival, thrombosis, leukemic transformation, fibrotic transformation. Now, you might hear, well, you might get something better in terms of hematocrit control, in terms of maybe the JAK to allele burden going down. And this is a classical marketing spin. They tell you whatever they need to tell you to sell their products. Nobody under the sun has shown that decreasing the JAK to allele burden translates into meaningful health outcome. No. Nobody has shown that. And they have their hit people all around, so-called opinion leaders, going around and making these claims that are completely unsubstantiated and scientifically disingenuous. So in general, you try to avoid medications if you can. So that's how I approach my patients.
Wow, okay, great. So can you a little bit talk about the aspirin and how much evidence we have, especially for the low-risk patients?
Well, in general, as you probably know, the value of aspirin was established about 20 years ago in a controlled study. And even before that, there was a suggestion. Professor Barbui and the Italian group has really given us all the information we need that is helping us manage our patients. And a publication about 20 years ago in NEJM clearly shown that aspirin therapy is better than no aspirin therapy in terms of reducing the risk of thrombosis in both low and high risk patients. So that's why it's a universally accepted treatment. Now one can argue, how hard is the evidence and this and that, but in general you're not losing much. And in fact, now there is even more recent information showing that twice-a-day aspirin might be better than once-a-day aspirin. So aspirin is clearly of value. There's a lot of retrospective studies, especially in ET, that corroborate this impression. Obviously, high-risk patients clearly need aspirin, especially those with arterial thrombosis. So there is definitely good evidence for the use of aspirin in both low and high-risk patients.
Okay. And then I think we made the comment on this, right?
Yes, correct.
Right. Yeah. So, and also you touched upon the cytoreduction and the evidence. What is the evidence of that outcome measures, right? Anything that you want to add on this?
No, absolutely. I think the cytoreduction, remember, when you think of cytoreduction in PV, don't be dogmatic. The evidence is not very hard in terms of, why do we treat patients with PV? It's not to prolong their life. It's not to cure the disease. It's not to prevent leukemic progression. It's to prevent thrombosis. And in that context, the data we have is soft. I wouldn't say it's very hard, but we use it because there is some data to that effect. So we do recommend cytoreduction for older patients above age 65 because we feel that we're doing them a favor. But remember, not everybody tolerates the cytoreduction, whether it's interferon or hydroxyurea. And that should be a sign for you to kind of step back and say, what am I trying to do here? I'm trying to prevent thrombosis. Oh, by the way, I have another patient with AFib. I'm giving them Eliquis. All right? Why can't I do the same for my patient with PV? If I am trying to prevent thrombosis, there is nothing magical about lowering the platelet count or this. The important thing is to prevent the thrombosis. So usually, if my patients do not tolerate, I just put them on Eliquis 2.5 twice a day with one baby aspirin a day. Beautiful combination. I call it the Tefferi cocktail for my patients so that they remember it. And it is a very nice combo. And then you don't have to run around and the neutrophils are dropping. I can't use hydroxyurea. The patient is getting leg ulcers. Forget about it. Just go with Eliquis 2.5 twice a day plus 1 baby aspirin a day. Nice combo. And move on until somebody comes up with a drug that's actually disease modifying.
Okay, wow. I did not know the Eliquis with this aspirin or for the intolerable patients. Great. So so we touched upon this, but can you also a little bit elaborate on, you know, the VAF, the disease burden kind of decrease and the long-term consequence of this, especially the hydria-related possible complications?
So there are 4 drugs that are currently used on and off for PV. One is hydroxyurea. Second is pegylated interferon. Third is busulfan. Fourth is ruxolitinib. All 4 drugs have been shown to be associated with decreasing variant allele frequency, decreasing allele burden. All of them. Busulfan is actually even fantastic. All of them. But none of them give you the molecular remission that you know from imatinib, for example, in CML. We're not talking about deep molecular response of less than 0.01 here, okay? We're talking, oh, it went from 60 to 40. Or, oh, it went from 2% to 0. That's not a molecular remission. Tell me about cytogenetic remission. Tell me that the 13q minus disappeared. Then you get me excited. Tell me that the morphologically, independently reviewed, that the morphology now is completely normal. Then you get me excited. But you'll never get me excited by saying that the 40% went to 20%, and therefore I have a molecular remission. So in general, these remissions, genetic remissions, are very dubious, in their interpretation. Now, the hematologic remissions, again, there are no good prospective studies. And there are actually several studies that suggest that the value in meaningful health outcome not always correlates with the actual hematologic remission that you get, whether it's partial, complete, which is all that you get together over Starbucks and you say, we'll call this complete and this will call this partial. There's absolutely nothing there to suggest that what we measure currently with our standard response criteria correlates with actual meaningful health outcome. Nothing. But they use this for drug studies, design of drug studies, because you need some sort of a target. But they don't necessarily, the true target, the true primary endpoints should be thrombosis, should be progression to myelofibrosis. These are the true ones. All the other ones are very artificial. It helps drug companies get approval for their drugs. It doesn't necessarily help the patients or advance the science.
So we can move, and I think you also touch base on this pegylated part, right? Anything that you want to add here?
No, I think all of your audience should know that there are now 3 randomized studies in PV comparing hydroxyurea to pegylated interferon or phlebotomy to pegylated interferon. And in all of them, none of them have shown superiority in terms of meaningful health outcome. In other words, first of all, they're all very short-lived. In other words, the follow-up is very short in all of them. And nobody really can say anything with a short follow-up. You have to die first before you start talking about survival. and these patients, the median survival is 35 years for young patients. All right? They're not going to die anytime soon. So you can't really start talking, because if you start talking about survival, it's all artifact and noise. You shouldn't start talking about that unless you have a follow-up of 10 years or 20 years. And in terms of thrombosis, you might, but again, Unfortunately, our good drugs are so good that they're causing a problem for drug companies because it's very difficult to show improvement over aspirin. So now they have to scramble. So they have to say, well, maybe we will use this as a surrogate. Maybe we will use the allele burden, what have you. So all of them have shown that the interferon can suppress the allele burden more than the hydroxyurea. This is common knowledge. We knew this years ago. There's nothing new there. Question is, does that translate into meaningful health outcome? And nobody has shown that. So that's my perspective on the matter.
Okay, great. So when do you use this mutation enhanced IPM? I mean,
so you have to remember about mutation enhanced or molecular prognostic models. Okay, when you talk about prognostic models, you have to always remember that these mutations can be applied to a simpler prognostic model. In other words, globally speaking, you have to start with what is easily available information. So for PV, easily available information is how old you are, whether there is a history of thrombosis, and whether you have a JAK2 mutation or not, this or that, right? Basically, this is very simple. And you make the risk category, right? You say low risk, no thrombosis, young patient, and high risk otherwise. You start with that. And then after you start, you say, okay, now can I further prognosticate within the low risk, within the high risk? That's when you start thinking about mutations. And clearly in PV, the presence of abnormal karyotype or certain mutations like SRSF2, like IDH2, and possibly ASXL1 might matter in terms of prognostication, might matter. So then you start incorporating these. So in other words, if you have a low-risk patient with these mutations, then you say, well, this might not be low risk after all. There might be a higher risk of progression. The question is it actionable? Are you going to do something about it now? No. That doesn't give you the ticket to do transplant for this patient or affect your management. What it tells you is watch out. This is the kind of patient who might go into transplant. So you follow those patients carefully and introduce the transplant option earlier than later.
Okay. So let's say this patient started on hydrea, phlebotomy, and then despite the maximum dose, he's been on hydrea, he's having this intolerance problem, ulcers, night sweats, and his spleen get expanded more, and so the patient switched to pegylated. So when do you consider that the patient is not able to do well on hydrea? What's your criteria? Do you have any?
There is no criteria. This is a clinical decision making. A good clinician does not require criteria. All right? A good clinician does not require guidelines. Guidelines are for stupid people. They're not for good clinicians. Good clinicians can look at everything because everything depends on the individual patient. The individual patient does not follow guidelines. They have their own disease. It's up to you. I mean, you're getting paid very well for being a hematologist. If we're all going to stay on guidelines, why do you need to be? You can go to Google, all right? If you're being paid this much, the minimum you can do is try to get all this information in your own brain and apply it to your individual patient. That's what a master clinician does. It's not running into guidelines and this guideline said this and this guideline, this is very disgusting as far as I'm concerned. I think you need to channel the energy towards that particular patient rather than running around, in search of guidelines. So again, this holds for this hydroxyurea is you're treating the patient, Okay, you don't need Tefferi to tell you whether that patient is tolerating or not. You will know. The patient will tell you. You see the everything, you see the leg ulcer, and these are bad things. And you say, okay, it's time to switch. You don't need anybody. It's common sense. If you find something bad, change it. Reducing the dose is not going to, especially with leg ulcers, reducing the dose is not going to help you. You got to change it. And then it's very easy now that we have pegylated interferon, you know exactly where to go. That's the most logical path is to go to that. Now, if you fail pegylated interferon and this, then it depends on what the context of failure is. If the context of failure is that the spleen is getting big and you are having more and more constitutional symptoms, well, that's the patient is telling you, I am transforming into myelofibrosis. Well, then you use ruxolitinib. If the pattern of failure is, oh, spleen is fine, it's just that I can't control the things, the counts, well, then you go to busulfan, which is much better drug, longer track record, and unlikely to affect the immune system as much as does the ruxolitinib does. So you have to kind of, this is how you just play the game.
Great. So I think you also covered the busulfan in this question.
Yes.
But the question is going to be, when do you use the combination or ever use it?
You know, you can never say never. Again, it is the clinical situation. For example, let me tell you about a patient of mine, which I'm seeing this, you know, I've been following this week. And she had, and she doesn't have PV, but she has myelofibrosis. And we tried a number of drugs, including Jakafi, for her spleen. It didn't help much. So I had to have her get a splenectomy. So she just had a splenectomy. She's doing well. But, you know, as expected, her white count and her platelet count is skyrocketed after the splenectomy. She's still on the Jakafi. All right? So she's getting some value from the Jakafi, and I want to keep it because I don't want her liver then to start going up after the splenectomy. But Jakafi is not the best drug to control high platelet count and high white count. So this is the scenario where I might add hydroxyurea to control the platelet count and the white count while keeping her on that. Do you understand me? So this is the kind of the scenario. But that scenario is not going to be in any book or in any guideline. The scenario is going to be in your brain, in your way of logical thinking, of doing what to do for what and why. And so that's, but otherwise, all this interferon combined with ruxolitinib, these are all publication purpose or approval purpose in exercises, not really something that's actually makes sense to do for a patient.
Okay. And then can you also a little bit go over the how you, if you want to stop the ruxolitinib?
Yeah, I think in general, I mean, it's very clear now. I mean, I think I published this many years ago. I mean, immediately after ruxolitinib was approved, I think in 2011, that if you just stop the ruxolitinib, the patient might go to the ICU because of immediate SIRS-like syndrome with respiratory distress and what have you. And it's not very clear why that happens. And interestingly, I have not seen this too much with the other JAK inhibitors like momelotinib, fedratinib, pacritinib, but I'm sure they might occur. But I haven't seen them that. And the thinking is that the way ruxolitinib works, in binding the ATP binding site and blocking it, that it might result in accumulation of phosphorylated JAK2, and that when you stop it, it just kind of flourishes, kind of thing. It's so in general, based on that, we have been just kind of going, well, take half of what you were taking for about 3 days, and then cut it out in half again in another 3 days, and keep it at 5 for another 3 days and stop. So usually over a week or over 10 days. And I suspect that we do the same if the patient is already on ruxolitinib with PV. If we wanted to wean it off, then wean it off over 7 to 10 days. There is no real criteria on how you do it. You do it any which way you want. Just taper it down. I don't think you want you ask someone to tell you how you win prednisone, right? On some patients on prednisone, you just use any which way you want, depending on which side of the bed you wake up. So that's what it is.
Okay, great. So also, can you touch base on your case? So when would you consider the radiation?
So first of all, obviously this is a PV talk, so never in PV. I don't consider splenectomy or splenic irradiation in PV. If I am considering that, that means the patient has transformed into myelofibrosis. Now, when they transform into myelofibrosis, currently what we use is JAK inhibitors because they are easier than either radiation or splenectomy. And now if they fail, then my choice is splenectomy. And it definitely, especially if you're preparing the patients for transplant. So obviously, pre-transplant, you want to use JAK inhibitors, but you're not always successful. I mean, really, you're not always, and the transplanters would not touch the patient unless you reduce the spleen to less than 15 centimeter palpable or less than 10 centimeter palpable. They like to take the patients with very small spleen or no spleen. And so if you can't do that, then you do splenectomy. Now, if you can't do splenectomy for one reason or another, then you can use splenic irradiation. There is a new article just published in the American Journal of Hematology. Very nice article, a global collaborative effort that I think it's from Nick Gagelman, and it gives you that comfort that people have used splenic irradiation and it helps. So when you cannot do the splenectomy, then that's when you consider radiation.
Okay. And also, I think this is the last slide. Can you talk about the hepcidin mimetic medication that was just recently published, the phase 2 trial?
Yes, yeah, you're right. So one of the things in PV, we always talk about survival, leukemic progression, fibrotic progression. We talk about all those things. But we sometimes forget that the patients were fine. We're going to live for 35 years. Sometimes a subset of patients, not everybody. Now, you have to remember, some patients with phlebotomy, they need the phlebotomy maybe once every 6 months. And they're fine. No drugs. They're lovely. They're happy. They don't have any symptoms from iron deficiency. Nothing. And then there are patients who require phlebotomy every month. Very inconvenient. And then they become severely iron deficient and they get symptoms. So there is this group of patients here that might need an alternative to phlebotomy. Obviously, if these patients are high risk, you're going to put them on cytoreductive drug. You're going to put them on Idria. You're going to put them on interferon. So here, you don't need an alternative to phlebotomy. You already have an alternative. So we're talking about low-risk patients. Low-risk patients. Can you have an alternative? In other words, can you make them iron deficient? The purpose of phlebotomy is to make the patient iron deficient so that they can't produce a lot of red cells. That's the purpose. Therefore, can you make somebody iron deficient without phlebotomy? And that's where rusfertide comes in. All right? That's where, or not only rusfertide, but also all new investigational drugs that are trying to either mimic hepcidin or cause induction of hepcidin production, endogenous hepcidin production. So there are hepcidin inducers and hepcidin mimetics. And basically what this does is it works exactly like hepcidin. It blocks the availability of iron to the red cell precursors. It blocks the ferroportin, which is the door, that's the channel that is being used to get iron from reticuloendothelial cells into the blood so that it can be carried by transferrin and taken into blood cellular precursors. If you block it, then they're starved for iron, so they're iron deficient, but your stores are still replete. So that's what rusfertide does, and basically it works by decreasing the phlebotomy requirement. In fact, it's almost 60% success rate. But the question is, how much more convenient is it compared to phlebotomy? For somebody who's doing phlebotomy once every 3 months or once every 4 months, they might not want to be stuck because this is a subcutaneous injection weekly. And almost everybody gets a reaction. All right? And by the way, something that you need to know, that there was a 7% incidence of treatment-emergent skin cancer. If you read that, because most of the people just look at the efficacy, they don't look at that. And if you remember, this drug was held because of a similar issues in animals, in mice. So there are issues. So if I had a polycythemia vera, and if I can just do phlebotomy every 3 to 6 months, I'm happy. I don't want, no drugs is always better than drugs for me. I don't want to get stuck every week with that and have a reaction and possibly put myself in danger to skin cancer. So in other words, I'm not saying that this thing causes this, that. I'm saying is we need to read the whole paper, not just part of the paper. And therefore, there is a role in this kind of approach. But the problem is, what if that person says, well, why don't you just give me a little bit of interferon? Just give me a little bit of interferon. It will control my hematocrit. And by the way, it will also control my leukocytes, my platelets, okay? And also might lower my allele burden for whatever, that matters to. In other words, there are other options that are alternative. So within that scope, you have to say, well, where am I going to use it? And if I said I'm going to use it, is that better than interferon? And what have you. So it's really a big box right now. I hope I answered your question.
Yeah, very, very clear. So, I think you also mentioned about this. We have only a couple minutes left. I want to give everyone a chance to ask their question if they have or their comments.
Now, this last question, what I think in the future is, I think all of you know that PV is closely associated with a JAK2 V617F mutation. Everybody knows that. Which means it's a very good opportunity if we can find targeted therapy that is specific to that mutation, we can make a difference. The problem is that the current JAK inhibitors are not selective for the VF mutation. They're not selective. There's just general JAK inhibitors. And as you know, structurally, that binding site is conserved across all JAKs, and therefore it's very difficult to be selective. Very difficult to be selective. So now the effort is to find a target that might selectively affect the mutant JAK2. In other words, they're looking at domains outside of the ATP binding site. They're looking at actually the pseudokinase domain where the mutation actually resides on, and other domains. So the future is going to be on next generation JAK inhibitors that might be more selective to the V617F. And to me, that's the path forward in PV.
Thank you, Dr. Tefferi, again for your insights. I learned quite a bit. I hope everyone enjoyed this session. I hope to host you for another session for ET, hopefully. Thank you again.
You're very welcome. Have a wonderful day, everybody.